Okay, so we're going to go over a specific fracture type that we can cover. This is a 20-year-old female who was injured back in 2016, restrained, loss of consciousness, no recollection of the specific events of the accident. And then she was transferred to our facility for further care. She's a relatively small lady, healthy, no other associated comorbidities. She has really no associated injuries with this. The head injury was rather brief and resolved. So this is her AP pelvis x-ray. As you can see, she's got disruption of the iliopectineal and ilioischial line, and you can see that these are disrupted in continuity up here near the greater sciatic notch. There's no specific fracture line through the weight-bearing surface, and there's a fracture line going up through the iliac crest. You don't really see a displacement of the ischium, or there's no displaced fracture of the ischial ramus, and there's a little bit of a subluxation of the pubic symphysis. Okay. On the obturator oblique, you can see that the entirety of the joint is medialized. The disruption of the iliopectineal line, or the anterior border of the bone, is very high. You can see here is a specific spur sign. And on the iliac oblique, the fracture through the ilium, through the weight-bearing portion of the joint is visualized, and the displacement of the posterior border of the bone and the greater sciatic notch. So the CT scan was obtained, and this will show you the fractures of the anterior column. You can see that showing up there. Some fragmentation along the along the pelvic brim. The fracture as it approximates or goes into the SI joint. And then the posterior column fracture there, and the relatively simple split through the weight-bearing surface of the acetabulum. This is the three-dimensional reconstructions that were obtained. So you can see here's the fracture lines of the acetabulum. There's the anterior column that's pretty easily visualized. You'll see in the gap, there's the fragmentation that occurred on the compression side of the fracture. There's the intact ilium, the simple fracture through the posterior column at the rim. You'll take note here that there's minimal displacement at the rim, consistent with maintenance of the capsulolabral junction, which can facilitate reduction. You can see that the fracture is very high on the internal aspect of the bone, and you can see that it enters the SI joint right here, and this is actually the anterior part of the SI joint of the intact ilium. So her diagnosis is an associated both column acetabular fracture with SI joint involvement. The question is, do you need any additional workup, and what would be the surgical plan for this specific fracture? Do you want me to move forward, Mark?
Yeah, I think so.
Okay, so these are the specific views that we're looking at, and the complicating factor is the fact that the fracture enters the sacroiliac joint, and you're really not going to get a very good visualization of the majority of the fracture through the ilioinguinal approach. And also this fragmentation from the compression side, or the outer aspect of the ilium, that is displaced into the internal aspect of the pelvis. And then your question is, do you do a much bigger approach to put together such a simple fracture line, or do you do a more limited approach and accept maybe some secondary surgical congruence at the joint?
So Mike, do you think, if we go back to that, one slide?
Yes.
So that CT obviously is done with the head significantly medialized. Do you think if the head was in a more lateralized position, any of those would improve their position and maybe change your decision making?
I don't know. If you look here, I think some of them are actually trapped on the inside of the intact ilium, on the iliac oblique that you see on the three-dimensional reconstruction. So these are actually trapped inside of the intact ilium, which
Right.
would
It seems
also
like the posterior column's
possibly complicate
incarcerated.
it. Excuse me?
It seems like the posterior column could be incarcerated on the front of the sacrum.
Yeah. So that would be the challenge of what you could do from an ilioinguinal approach, because the vast majority of these fractures are treated through the ilioinguinal. And I chose a lateral position, extended iliofemoral. I waited a couple of days for the flap to calm down, and we did it with not too much blood loss. But so the question is, why not do it through the ilioinguinal, I guess? And if you look at the bone here, this would be your visualization on the internal aspect of the pelvis. So through the lateral window, you'd be able to see the fracture confluence right there, but you really wouldn't be able to follow the fracture of the posterior column down along the quadrilateral surface or into the greater notch, because it would disappear into the SI joint, where with approaches to the outer aspect of the bone, you'd see that you'd be able to retrieve the fragmentation, and you could make these simple fracture lines actually quite easily, or you could easily reduce these simple fracture lines on the outer aspect of the bone. And I don't really think you need to, but you could also have access to the joint for visualization of your reduction.
Could I ask Keith a question?
Sure.
Keith, do you think, go back, do you think that the extended ilioinguinal, as described by Jeff and Reinhold, would be an option here?
And this is really not a good pattern for that, because the anterior extent of the posterior exposure really is the posterior border of the medius pillar. So you'd be right at the very limit without any ability to actually key in those fragments. So it's much better for the unstable inferior part of the sacroiliac joint, or a portion of the greater sciatic notch, which extends up into the inferior portion of the joint that you can't see. You know, I would, in a situation like this, I always really wondered, with these relatively simple articular patterns in both columns, why, and I've tried it actually, and now I know why, but why we can't approach it like we would approach a plateau. And that is, we basically put the joint together first and then reattach that to the metaphysis or diaphysis. And so I think I would have been tempted to try to get a picture of this in traction, probably in a lot of traction. And you know, I've never been able to execute it, but I have tried on several occasions to distract as much as possible and then try to get the anterior posterior columns reduced. And then I'd be just left with a transiliac disruption and then reattach the joint to the inominate bone. I've come close several times, but I've never really made it. So, and I mean, I think that's the question a lot of people have. I mean, we don't address pilons or plateaus or distal femurs this way. And that's largely because those are direct articular reductions as opposed to these being indirect. But if we had the ability to do an indirect reduction, which was anatomic by creating space between the intact inominate bone and our two columns, it's an intriguing possibility.
So do you think if there were rami fractures, either right or bilaterally, that would be enough mobility to allow you to pursue that strategy?
I think on the ipsilateral side, it might help. I think on the contralateral side, my experience is that they almost always make things worse.
Mike, there was a question from a participant asking why you couldn't do this through an AIP approach. Maybe go backward to that, to the view of the inside of the pelvis.
Yeah, I think this would be the most challenging part from the AIP, is that if you get to this portion from here, I think you could maybe see the backside of this fracture. This disappears over the front pretty early, and this access would be kind of challenging. You'd have to have the lateral window along with it. And really the only benefit of the AIP would be to apply fixation, but really not assess the fracture.
Any other questions from, or any other points from the faculty? Would anybody have tried this through an ilioinguinal? Phil or John?
No, I tried this maybe 20 years ago before I had the wisdom that was elucidated tonight, and you can never really get it perfect. So I think that's the problem that's already been discussed. So I generally wouldn't try it in this particular pattern.
Yeah, I think at best you'll end up with a surgical secondary congruence, but at worst you'll find that you can't get the posterior column reduced, and then you're not going to want to reduce the anterior column because you're going to lose all of your options. All right, Mike. So so you chose lateral position and an extended approach. We saw.
Correct. And so here's our immediate.
What was your sequence of reduction?
What's that?
What was your sequence for reduction?
Okay, the sequence for the reduction, I'm going to go back a couple of slides and just to look at the 3D. The sequence of the reduction, let me see if I can find the lateral aspect of the bone right here, Mark, sorry. So the sequence would be to reduce the anterior column to the intact ilium and then the posterior column to the confluence of the intact ilium and the anterior column. So you would start with your reduction here, with traction, of course, as Keith pointed out, reduction at the crest, reduction along the outer aspect of the bone here. You'll see there's a couple of mini fragment screws that I placed these fragments back along the obliquity of their fracture lines to help get this read, and then reduce the posterior column to that.
And just a 2-screw technique to distract the anterior column and disimpact from the front of the sacrum?
Yes. So here's the post-operative x-rays. So immediate post-op plan for me is I drain the flap always with the extended iliofemoral until the fluid levels are quite low, actually less than 30 a shift. I keep them in bed for 36 hours with an abduction pill to allow the flap to calm down. Use indomethacin for 3 weeks for heterotopic ossification prophylaxis, Lovenox 3 weeks, transitioning to aspirin. 30-pound weight bearing or 15-kilo weight bearing heel toe gait for at least 8 weeks, but with the big fragments, probably 8 weeks is sufficient. And no active abduction, no passive adduction due to the trochanteric osteotomy for the mobilization of the gluteus medius.
And
so here the patient is.
Osteotomy different than the trochanteric osteotomy we discussed with the Gibson and the Coker?
No, it's like the one that I showed in my talk a week ago. So you'll take the minimus off of the anterior aspect of the trochanter, tag that, and then you'll cut a lateral to the piriformis, much like the surgical dislocation, but you will have to detach distally the insertion of the vastus lateralis to mobilize that, unless you could take it off as a very long sleeve, but I've just taken it off at the vastus ridge personally. So this is the patient at 2-year follow-up, maintained reduction, and actually excellent functioning hip, back in college with no complaints, and actually back to sports. So thank you.
Yeah, that's a great case.